Good evening, everyone. Thanks for joining us for our TIF Talk. My name is Wendy Profit. I am with Endogastric Solutions. And with us this evening, I'm pleased to introduce you to Dr. Sham Thakkar. We'll get to Dr. Thakkar in just one moment. Also, Lynn McFadden, my colleague, will be with us running the question board. So please post your questions in the comments section for Dr. Thakkar. We'll get to those as we're able this evening during our conversation. Dr. Thakkar, our esteemed guest, earned his Doctor of Medicine degree from Temple University and went on to complete his internal medicine training at the University of Pittsburgh Medical Center and his Gastroenterology Fellowship at Allegheny General Hospital, Drexel College of Medicine. He then went on to complete a specialized Advanced Endoscopy Fellowship at Beth Israel Deaconess Medical Center, Harvard Medical School. Along with his clinical work, Dr. Thakkar has served as the principal investigator on numerous studies, with his most recent research focusing on natural orifice surgery and optimizing colonoscopy using artificial intelligence. Dr. Thakkar has served as faculty at numerous national and international conferences, including serving as an ambassador to Vietnam for the American Society of Gastrointestinal Endoscopy. He's been recognized for his innovation, research, and contributions to the community by the American Society of Gastrointestinal Endoscopy, the American College of Gastroenterology, and the National Pancreas Foundation. He currently serves as Director of Advanced Therapeutic Endoscopy at West Virginia University Medicine in Morgantown, West Virginia. Welcome, Dr. Thakkar.
Thank you for that kind introduction, Wendy, and thank you for having me. Delighted to share the time with you and with the audience today, talking about gastroesophageal reflux disease.
Thanks for being with us.
Yeah.
Okay, well, for those who are tuning in, we appreciate you being here this evening. Dr. Thakkar, we'll go ahead and jump right in. If you could just please describe for us, what is GERD? What are the physiological things that lead up to it? What do people experience when they have GERD?
Yeah. So GERD is gastroesophageal reflux disease, and in essence, it's the upward moving burn. The typical description of it is an upward moving burning sensation in the chest that we describe as the hallmark symptom of heartburn. Now, all of us experience gastroesophageal reflux to some extent. There is a sphincter that connects the esophagus to the stomach, known as the lower esophageal sphincter, and it's transient lower esophageal sphincter relaxation that leads to reflux. However, those that get symptomatic from that reflux really have the disease of gastroesophageal reflux disease. And it's in those patients that we look to provide therapy in order to optimize their outcomes and relieve their symptoms. Complications can, of course, arise from gastroesophageal reflux disease. That includes Barretts Esophagus, which is a change in the lining of the esophagus that can predispose to esophageal cancer. Other complications can include hoarseness of the voice, asthma. These are all symptom or late manifestations as well of gastroesophageal reflux disease. And there's also extraesophageal manifestations. So patients can have symptoms like ear ringing, or again, hoarseness, or dentition changes, all related to the reflux disease.
Interesting. You know, I don't know that I've heard anybody describe ringing in the ears as a symptom. Can you talk a little bit about what leads to that?
Yeah, that again is an extraesophageal manifestation, but in essence, it's the upward moving refluxate that comes into the esophagus, and sometimes there's different receptors in our esophagus or in the upper esophageal airway even that can actually become activated and lead to some of these symptomatologies.
Interesting. Thank you very much. So for patients who have GERD, how do they typically manage those symptoms?
Great question. So for patients that have gastroesophageal reflux disease, the most common way to manage the disease is with proton pump inhibitors. It's a medication that's prescribed by a physician, and in essence, it's taken generally once a day, a half hour before breakfast, to help manage the gastroesophageal reflux disease. And really, the way proton pump inhibitors work is they inhibit the acid secretion so that the reflux, when it happens, isn't acid burning that hits the esophagus. It's been a very stable therapy for gastroesophageal reflux disease over the past couple of decades, and patients have responded to it well.
Very good. Can you talk a little bit about just the changes that people can make prior to a therapeutic treatment, as far as any type of lifestyle changes that folks are able to adopt easily versus not?
Yes, excellent point as well. So when it comes to gastroesophageal reflux disease, not only is the medication, the pharmacotherapy way in which we manage it, but we also work on lifestyle modifications, we call it, and phase one anti-reflux regimens, we refer to them as, in terms of helping patients manage the gastroesophageal reflux disease. And this can include avoiding triggering foods. It can involve weight reduction. We know that generally when patients become overweight, that they can become more at risk for reflux disease. It can also involve sleeping with the head of the bed a little bit elevated so as to minimize the acid exposure in the night into the esophagus when a patient lays completely reclined. And then finally, another way in which we oftentimes recommend is to avoid eating late meals, to have their meal well before bedtime, 2 to 4 hours before bedtime at the minimum.
Excellent. Thank you very much. So, can you talk a little bit about the process for determining if a patient has GERD and why it's important to find out for sure?
Yeah. So when a patient presents to the office, they oftentimes have hallmark signs and symptoms that are very consistent with gastroesophageal reflux disease. And one way to make the diagnosis is not only by obtaining those clinical symptoms, but to prescribe a therapy and see if they respond to it. If they respond, it becomes very pathognomonic for gastroesophageal reflux disease. Other ways in which we use to manage to do diagnostic testing to help us understand the presence or absence of gastroesophageal reflux disease is what we call pH testing, where we may place a probe in the esophagus that measures the acid exposure. And by measuring that acid exposure or the total acid exposure time, that can help us better understand if there is the presence of gastroesophageal reflux disease. Another test that we oftentimes consider is the upper endoscopy. That's where we actually take a look with a camera down the esophagus, stomach, and small intestines and examine the lining of the esophagus. Sometimes we can see inflammation of that esophagus lining that is characteristic of gastroesophageal reflux disease. We can even see later stages of complications of that inflammation, which is esophagitis, which is essentially ulceration or breaks in the normal lining that is consistent with gastroesophageal reflux disease. And so these are various tests that we can do. One other test we can also do is at the time of the endoscopy, if there aren't really findings suggestive of gastroesophageal reflux disease, we can implant a capsule that passes on its own in 2 days, but can measure the acid exposure over 2 days time period. And in that way, very much the size of a pill, essentially, and that sits in the esophagus. And then again, it passes on its own, but it gives us good information as to the presence or absence of gastroesophageal reflux disease. The reason why someone might do some of these tests, especially the upper endoscopy, is when symptoms present in an individual that's a little bit elderly in age, as an example, or perhaps someone even over the age of 50, because we want to make sure there aren't any complications of gastroesophageal reflux disease or anything mimicking that. Someone who has alarm symptoms, such as unintentional weight loss, or some blood in the stool, or some microscopic anemia, that's highly suggestive of some form of GI tract bleeding. and we want to make sure that there isn't an early esophageal cancer or something more worrisome going on as a complication of the gastroesophageal reflux disease. So for these reasons, we may decide on various tests to choose, but ultimately it's the symptom complex that the patient presents with in the office, and then perhaps some of this diagnostic testing to ultimately make a diagnosis of gastroesophageal reflux disease.
Excellent. Thank you very much. Regarding Barrett's esophagus, which you mentioned as far as a change in the esophageal lining, what test is there only really one test that can be done to identify if a patient has that?
So Barrett's esophagus is a pathologic diagnosis. And in other words, though we can recognize it with endoscopy, it really is a tissue diagnosis to make that diagnosis. And like we kind of mentioned a little earlier, it's a changing in the lining of the esophagus that predisposes to the development of esophageal cancer. It increases the risk of esophageal cancer about 0.5% chance per year to a lifetime risk of about 5 to 10%. Those with Barrett's esophagus are 30 times more likely to develop esophageal cancer than those without Barrett's esophagus. And for this reason, it's something that we want to keep a close eye on when we find it and surveillance it, because the last thing we want is this to progress into esophageal cancer. Now, oftentimes it can be preceded by some precancerous change in the Barrett's esophagus, and we can actually treat that and get rid of it before the esophageal cancer forms. But one of the best ways to get rid of or to treat Barrett's esophagus is actually to treat the underlying reflux problem. And by treating that, either through a medical therapy or through an endoscopic therapy or through a surgical therapy, we can control it and prevent and help prevent that Barrett's from progressing further. To answer your question as to can the diagnosis only be made with an endoscopy, there are a few tests available that can help us acquire tissue by placing a device down through the mouth into the esophagus, into the small bowel, but not necessarily a camera, or through the nose. But for the most part, endoscopy and biopsy is the mainstay of making that diagnosis.
Thank you very much for that. I appreciate it.
Yeah.
Before we jump over to you, Lynn, I'm seeing that we've got some questions coming in. Just one quick question, and then we'll go ahead and talk with Dr. Thakkar about a couple more things. Just true or false, medications can cure GERD?
That's a great question. So I would say false, in the sense that medications can stop the acid from forming, but it doesn't stop the reflux from happening. You know, it's one of these things where we're using medications to help manage the disease, but to cure gastroesophageal reflux disease is really to stop the reflux disease manifestation in the esophagus.
Very good. Thank you very much. Okay, Lynn, over to you.
Wonderful. Thank you, Wendy. So Dr. Thakkar, we'll start with Tom. We have quite a few questions coming in, but I'm going to start with Tom's questions. Is it okay to use PPIs for more than 20 years?
So PPIs are medications that help control the acid formation. Okay, PPIs have been shown to be very effective at that problem and helping to control and helping to manage the symptom of gastroesophageal reflux disease. PPIs, like any medication, have a risk-benefit profile. For the most part, they are deemed to be a very safe medication. However, they do increase your risks for certain potential adverse reactions and for adverse events. One of the major risks of a PPI long-term is a small increased risk of osteoporosis. So that would be something where if you've been on a PPI for many years, that risk may exist for you. It would be good for you to have the discussion with your primary care physician or your gastroenterologist, the individual that's prescribed that proton pump inhibitor, about the potential risks of osteoporosis associated with taking that medication and your clinical history. If you have other risk factors for something like osteoporosis, that may be something to weigh as to whether to stay on PPI or consider an alternative therapy. If you don't have as much of a risk for that, then again, the benefits may outweigh that risk. In general, it's a very small risk, so the benefits tend, for the most population, to outweigh that risk. But there are other potential adverse events to PPIs. This can include diarrhea or abdominal pain. And if you have experienced any of these side effects, then that's also reason to have a discussion with your provider.
Excellent. Great advice. And thank you. We get a lot of questions around the PPI medications, how long to stay on them before seeking alternative options. So thank you.
I will add, there has been a lot of press around the potential risks of PPI with chronic kidney disease or potentially dementia. What I will say is that some of those studies have found some association. However, in those studies, there were a lot of confounding factors. Patients having diabetes, as an example, which we know are potential risk factors for these problems. So it's not clear as yet whether that's truly a link between PPIs and those diseases. But as we continue to investigate and look, those are things we're looking to explore.
Wonderful. Thank you. Next, I'll move on to Brian. Brian is asking or saying, I don't have heartburn, but I'm constantly clearing my throat. Could this be a sign of reflux?
That's another really good question. And the answer to that question is yes. There are a lot of potential extraesophageal manifestations of reflux, as we were talking about previously. One patient that I had treated had a chronic cough, and she just was not able to have this cough under control for over a decade. And ultimately, we actually performed an endoscopic procedure known as the transoral incisionless fundoplication on her to control her reflux disease, because we were able to demonstrate that she did have evidence of acid reflux. And we had a high suspicion that her cough was related as an extraesophageal manifestation of a reflux disease. We performed that TIF procedure on her, and I'll never forget it, because she woke up and instantaneously her cough was gone. She was in tears in the recovery room because she hadn't felt that way in over a decade. And so to answer kind of your question, can this be a manifestation? Absolutely. There's also a lot of other potential manifestations of constantly wanting to clear your throat. And that's something to see your provider for. And if they haven't found a good reason for it, it's definitely a discussion point to discuss. Could this be reflux disease? Should I see a gastroenterologist about that?
Excellent. Thank you for sharing that story. It's very heartwarming to hear such an immediate change, and just the emotion behind this disease. It really weighs on people greatly. Salome is asking, how do you determine when TIF, or the TIF procedure you just mentioned, how do you determine when that is the right procedure for your patients?
Yeah, I think that is a discussion point with the patient. So, we didn't talk too much about that endoscopic therapy as yet, but essentially, just to give a kind of a background, there are, as we've talked a lot about PPIs, there are also interventions that we can perform to treat reflux disease to stop it from happening. One is the TIF procedure. The others are the surgical procedures of the fundoplication or the links, where they put actually a magnetic ring in surgically to help prevent reflux from happening. These are all different interventions that we can perform. The TIF procedure essentially involves taking a look with the camera with the endoscopy, as we described, and essentially tightening the lower esophageal sphincter site and elongating it so that we prevent reflux from happening. It's somewhat similar to the surgical, what we call Nissen fundoplication, but it has a lot of benefits over the Nissen fundoplication in what we've seen as compared to the Nissen procedure, also without a lot of the risks associated with the surgical procedure. So I tend to prefer the TIF procedure over the surgical interventions. Plus, it doesn't rule out any surgical option down the road if need be. Now, the question as to when do we determine if a TIF procedure is the right procedure for the patient? I think part of that is definitely a discussion with the patient. So if the patient, as an example, has started proton pump inhibitor therapy, the PPI therapy, and has had problems with it in terms of side effects, though it's controlled the reflux, they may be having issues with abdominal pain, nausea, or diarrhea. That's someone I would consider strongly for a TIF procedure. Another individual that's young and looking at not able to come off of PPI therapy, and essentially they're looking at the therapy for several decades going forward. That might be someone that I would consider for a TIF procedure. Someone who's having difficulty, potentially even being able to afford the medication. This could also be another great candidate for a TIF procedure. And then someone who just wants to avoid taking medication, is looking for something to fix the problem and move forward without having to take medications. That is someone that I would consider. Finally, someone who might be at high risk for osteoporosis. We worry about this, especially in thin women who might not have as good bone mineral density, looking at later years in life. For those individuals, we might consider proposing a TIF procedure. It's not really one that I would say absolutely you should do this over this, but it's one where we would recommend something and weigh out the risks and benefits for each patient. So these are circumstances where I would definitely recommend it. But at the end of the day, we would have the discussion with the patient and individualize the therapy around them.
Yeah, it's a great point. Is everybody's different. So those discussions are key in determining that care pathway and what's right for that individual. So thank you for covering those things. Wendy, we do have a couple more, but I'll turn it back to you to continue on with some of the subjects in the agenda too.
Sure. Thanks very much. My next question was talk to us about the TIF procedure and how it works. I think we've definitely covered that. So can you maybe talk a little bit about number one, can you think of any things that patients have come into you and said, this is why I want this? What are the things that are important to your patients when they are considering these endoscopic therapies?
Yeah. So, when I typically find a patient that wants to wants to move forward with the TIF procedure, it's generally someone who does not want to take proton pump inhibitor therapy. Someone who feels like, this is something that they just don't want to be on the medications for the rest of their life. That seems to be a big hit. Another one is someone who's having real struggles with gastroesophageal reflux disease and can't tolerate the proton pump inhibitor, but wants an option that's not surgical. And another individual that might show up who is considering TIF is someone who's a little bit younger and been on PPI therapy, and though it's controlling, they're only in their early or mid 20s and looking at basically they haven't been able to come off of the PPI without having reflux disease. That's someone who might say, listen, I don't really want to be on this medication for the next 50 years, 60 years of my life. I understand about this TIF procedure. Can you tell me more? Those are typically the three that I often see that come seeking a TIF procedure.
Very good.
Outside of me having having to propose it as an option because they've already done their research and really looked for this option. Yeah.
Excellent.
Yeah.
So we do have several folks who often ask about the incidence of a hiatal hernia repair when they have GERD, and they're fighting that as well. Can you talk about the solution there for those patients?
Yeah. So TIF works really well for individual. TIF is a very straightforward procedure, I should say, to perform, especially in those without a hiatal hernia. Even those with a very small hiatal hernia, we can perform the TIF procedure without major issue whatsoever. It's, again, a very straightforward procedure to perform endoscopically. In fact, we generally book a total of an hour time in the procedure room, and it probably takes us about 25 to 35 minutes to actually do the procedure. By the time the patient goes to sleep and wakes up, it takes the full hour. But essentially, that it's a very straightforward procedure to perform in those patients. And those that have larger, medium-sized to larger hiatal hernias, that is something where we can't fix the hiatal hernia with the TIF alone. We would look to our surgical colleagues to work together and have them fix the hiatal hernia. And then at the same time, we would perform the TIF procedure as they fix it surgically. Then we can perform the TIF procedure. And in essence, it's kind of a concomitant procedure. So both procedures are done at the same time, one to fix the hiatal hernia and two to do the TIF to stop the refluxate. And in that way, we control the disease. And that's how we would work with patients with medium to larger size hiatal hernias.
Excellent. Thank you. Lynn, I'm seeing that you might have had another question.
We do. We've got Kawar. I hope I'm pronouncing your name correctly, Kawar. He's had some challenges. It looks like he's had a procedure. He's calling it the ring procedure, and he still has GERD. On top of that, he has H. pylori. He's been on antibiotics. It's been a couple of months. He's not fully recovered. And then he goes on to say he has heartburn and food that comes up in his mouth, but he's feeling a little bit better now. He's just curious how to control the acid reflux. And it looks like the ring procedure he had done was 4 years ago, and he's not finding reprieve.
Yeah, that's tough. The LINX procedure can be a very good procedure to treat reflux disease, but there can also be issues with there can also be cases where patients don't do well with that surgery alone. I think one of the things that we would say here is that there's a lot of potential possibilities that could be going on in this case, and it's really important to have a visit with an expert to kind of really focus the diagnostic workup so that we can determine the exact etiology, because the treatment plans would be different depending on the etiology of his symptoms. Though it sounds and feels like reflux coming up, a lot of one possibility here could just be truly that it could be that the LINX migrated. It could be that the LINX isn't as tight as it should be. It could be that the LINX is too tight and there's reflux in the esophagus. It could be a motility disorder of the esophagus where the esophagus doesn't contract in a coordinated fashion. And with all these different potential possibilities, the treatment algorithm would be different. Treating a motility issue versus a LINX related issue versus a reflux related issue are three different treatment pathways. So I would advise in this case to really follow up with a specialist when it comes to gastroesophageal reflux disease and have them do a thorough workup to determine the etiology of the symptoms that he's experiencing. Having a LINX procedure 4 years ago and having these symptoms is not normal, and it should be investigated to get it under control.
Very good. Oh, Lynn, I think we have you on mute.
I'm so sorry. We have Larry asking us, can TIF help with silent reflux? I feel a lot of liquid when I bend, but no heartburn.
So one of the great things about TIF procedure is it can help with all forms of reflux, okay, related to gastroesophageal reflux disease, okay? So if there is a symptom that is attributed to gastroesophageal reflux disease, it can definitely be helped with the TIF procedure. When you bend over and feel that sensation of free fluid coming up, again, that most likely is related to reflux, but there's also several other possibilities, so it should be investigated. One being, again, a motility issue of the esophagus. But that being said, if it is related to reflux disease, then absolutely, TIF procedure of essentially tightening that lower esophageal sphincter by doing what we call a 270-degree wrap and elongating that lower esophageal sphincter into the stomach side, really prevents that from happening. And one of the nice things about that form of a wrap is that it's not the complete 360-degree wrap that we see with the Nissen fundoplication. And those patients oftentimes develop symptoms of gas bloat, which we haven't seen as a major issue related to the TIF procedure. So that's why I say you get a lot of the benefits associated with the TIF that you don't see a lot of the adverse reactions that you see with the surgical procedures. So definitely that's something that should be investigated and looked at further as to the symptoms of fluid coming up.
Wonderful, thank you. And I think that you answered Lauren's question as well, asking if TIF can be performed with someone with a history of esophagitis. So you did touch on that a little bit too. So thank you for that. And then,
yeah, actually, just to kind of respond to Lauren, that actually, the esophagitis is a diagnostic finding of reflux disease. So by finding esophagitis, we know that that reflux disease is present. And once we do the TIF procedure, that's not only going to treat the underlying pathology, but also prevent it from worsening. One thing that's important, though, for Lauren's case is if she was diagnosed with esophagitis, it would be important to make sure that that is treated and cleared up and re-looked at to make sure there's no underlying pathology that the inflammation is covering that you can't find. You know, I had one patient present to me many years ago who had difficulty with reflux. And when I did the upper endoscopy, he had esophagitis, very inflamed esophagitis. We called it grade C esophagitis at the time. We performed biopsies at the site, and the biopsies were negative for anything other than esophagitis. And so I brought him back in about 4 weeks to relook at the area after we treated it with a high dose proton pump inhibitor, because I wanted to make sure the underlying tissue was normal. And in fact, it wasn't. And when we performed biopsies, we actually found cancer. So it's really important to make sure this esophagitis is cleared up and relooked at to make sure that there's no underlying pathology that's there. Not to scare anyone, it's just a possibility of something that can exist. More than likely, after the esophagitis is cleared up, it's normal tissue in there. Sometimes you can find some Barrett's, but that being said, it's just a good example as to why we should always follow it up and make sure that there's nothing else underlying that pathology.
Yeah, again, great advice. And as you said, it's just don't ignore those symptoms, don't ignore those things, and definitely consult with your physician if you're experiencing anything like that. So thank you for that. I think the last one I'll ask you here, and then we'll move on with Wendy's further questions. You're being thanked for sharing your statistics on Barrett's, so thank you for that. And Teresa's also thanking you for sharing your insight. She's saying, Teresa's asking, if the medication isn't working, what is my next step? And I guess you could speak to when is that next step appropriate?
Yeah, so if the medication's not working, that raises two possibilities. One is that it's gastroesophageal reflux disease that's not that's not well controlled with proton pump inhibitor therapy alone. Okay. Two is that the medication may not be prescribed the right way. Okay. And then a third possibility is it's not. I know I said two possibilities. Actually, three possibilities. The third possibility is that it's not the right diagnosis. So, in other words, if you're having symptoms and the medication that's prescribed isn't working, it's generally one of those three things. One is it's not, the medication isn't enough to treat it. Two, it's that the medication isn't prescribed in the right manner or being taken the right way. Or three, that it's possible that we have another diagnosis here, that we're being fooled that it's gastroesophageal reflux disease, and we need to look further for that diagnosis. Did that answer the question?
Yes, you definitely did. Thank you for that. I'll pass it back to you, Wendy, and then we'll hit a few more questions before we conclude.
Excellent.
Now, just to kind of follow that up, if it is gastroesophageal reflux disease that is made the diagnosis, despite the medication therapies not working, then I think, you know, it's time to look at TIF procedure or another intervention to treat that reflux disease. And there's no use waiting extensive periods of time, though I like to give my patients at least 3 months on the proton pump inhibitor therapy to know if they've responded to it or not. If it's been 3 months of especially high dose proton pump inhibitor therapy and they're not responding, then it's time to definitely move on. I wouldn't wait years, but definitely at least give them a 3-month high. If you've had 3 months of high dose PPI therapy, then I think it's time to move on.
Yeah, again, great advice as to when it's important to recognize those symptoms and seek some additional help and insight.
Right.
And on that point, I'd like to ask, because we see this happen all the time, right? People start experiencing some symptoms. Number one, when they have symptoms, how many times a week before you tell them, hey, you know what, you need to see somebody? What does that look like in your mind, Dr. Thakkar?
Well, I think the thing about reflux disease is we try and say, okay, having reflux disease, 3 times a week for this many years puts you at risk for Barrett's esophagus. But we really don't know that, to be true for every patient we encounter, right? There's demographics that are different. There's family histories that are different. There's a lot of environmental factors that can play in, diet factors that play into it. We haven't even touched really on that. But in essence, I think, if someone is having symptoms in general, they should bring it up with their providers. Even if it's just once a week or once a month, I think it's something that should be brought up because it's not normal to have excessive belching once a month, or to have burning in your chest once a month, or to have difficulty swallowing 3 times a week. Like, these are not healthy symptoms, and they should be treated and placed under control. It may just be that if it's so seldom that it can be controlled with lifestyle modifications alone, and that's great, but it's definitely something to discuss with your provider.
Excellent. Thank you. Yeah, oftentimes folks will have these symptoms. How many times do you see patients who say, well, I haven't really been to anybody until they're in your chair because they've been purchasing proton pump inhibitors from a commercial that they saw, and they seem to work for a while and now they don't any longer. Is that, do you see that?
Yes, we do. And, that also is a bit worrisome because we don't want patients to necessarily self-medicate themselves without consulting a provider. Those are the any medication isn't without its risks, as we kind of have alluded to. And then at the same time, there could be other manifestations that have developed or underlying pathologies that have been present that need to be taken care of, as well as the reflux disease. So for someone who may have been suffering with gastroesophageal reflux disease for some time and started taking proton pump inhibitor therapy, and maybe it got better, maybe even completely went away, there's a possibility that they have underlying Barrett's esophagus, could have some precancerous change in the Barrett's esophagus. And then when they come in with, other signs of weight loss or pain, or even difficulty swallowing, or food getting stuck, that's not a situation that we want to be encountering, because that's highly suggestive of an underlying tumor.
Wow. Well, there you have it, everybody. See your doctor, get the best treatment pathway laid out. Okay, so just jumping on back to the TIF procedure for a moment. We do have a lot of folks who, want to know, can you talk a little bit about what to expect the day of the procedure and then afterwards?
Yeah, so it's a pretty typical preparation for the procedure, like with general upper endoscopy. In essence, the patient is prepared by not having anything by mouth, the night before the procedure, and staying nothing by mouth until the procedure. And at that time, we essentially place an IV, obtain the consent. The anesthesiologist sees the patient, and so long as the patient is agreeable to continue to move forward with the procedure, consents to those risks and benefits associated with the procedure, those being the risk of small risk of bleeding, tearing, aspiration, but all really low, in general, less than half of 1%, and a same risk that we see with upper endoscopy in general. Then we move forward with the procedure. And once we do that, we perform the procedure, the patient wakes up. The procedure is performed under general anesthesia. So the anesthesiologist will actually manage the breathing completely on their side. And then after the procedure, that is stopped, and the patient is allowed to wake up on their own. And after that, then the patient basically is in the recovery area. I tend to watch the patients in the recovery area a little bit longer, about 2 to 4 hours. I like to keep an eye on them just to make sure they're not having any unusual symptoms. The only real adverse event that I've seen in any of the patients that I've done to date, I had one patient come back to the hospital 2 days later because they had some issues with coughing up some blood. And so when we did an upper endoscopy, they had some erosions that from the procedure that led to the bleeding. There was no intervention needed, and they did fine after that, just with some conservative therapy. I generally keep the patients actually on a proton pump inhibitor when I do the procedure, and I keep them on it after the procedure for about 2 months. Though over that time period, I'll have them on it daily for 1 month. Then for 2 weeks, I'll make it every other day. Then for 2 weeks, I'll make it every third day, and then I'll just stop it completely. So I kind of taper it off, the proton pump inhibitor. And the other thing that we should keep in mind is that after a patient undergoes a TIF procedure, the diet that they have is a little bit augmented. So in other words, we'll start with like a liquid diet. After that, we'll go to some certain types of soft diet. After that, we'll go to I should say pureed kind of diet. Then we'll go to a kind of a soft diet. Then we'll go a little bit more towards a harder consistency, and then we'll go back to a normal diet. And that will all also happen over like a 4 to 6 to 8 week period for the patient. And so those are the kinds of things to expect. In general, there's not a lot of like discomfort associated with the procedure. The patients tend to do pretty well. I had one patient require a few Tylenol like after the procedure, but that was about it.
Very good.
Yeah.
Thank you. Any recommendations specific to the diet on how folks should progress? Do you have any tips that patients have shared that have worked really well? And then also, some of the definite don'ts.
I'm sorry, could you ask me that one more time?
Just as far as the diet goes, how patients will typically progress. Does anybody bring you any secret recipes for success, things that worked really well, and then also things that really didn't work very well?
Yeah. So I've had, for the most part, the patients that have stuck to the diet have done really well. I've had a couple of patients who tried to advance their diet much more liberally than we had recommended, and found themselves in a little bit of trouble after that. And so, I think it's really important to just stick to that kind of slow, progressive diet change, and with that, I think the patients can tend to do really well. Okay. The one patient that I'm referring to, one of the patients I'm referring to at least, just started eating like spaghetti and meatballs within a week of the procedure, and it was a little too aggressive at that time, and so he found himself getting into trouble and was calling. And after we talked to him on the phone and had him back off on that, he did really well. So those are kinds of situations that are probable the don'ts, like you suggested.
Very good.
Yeah.
Last but not least, can we talk a little bit about just on the postoperative side, what physical activity should look like? When should people resume their normal walking, their work responsibilities, and then jumping on into when can they run again? When can they get back on the golf course?
Yeah. So I tend to favor a little bit of a conservative approach with it. In other words, if you're at work and do a lot of heavy lifting, I prefer light duty for a little bit of an extended period of time, typically at least 2 weeks or up to 4 weeks that I'll suggest that. In general, you can do your activities of daily living after the procedure, post-operatively, as soon as you recover. One of the things that we obviously say, because you had the anesthesia, no driving that day, no operating heavy machinery that day, no signing legal documents that day. Aside from that, really the next day, we're okay with you going to your activities of daily living in terms of going up and down steps or walking, or, doing some light housework kind of things, but no heavy lifting. And the heavy lifting I like to try and avoid for about 2 to 4 weeks. Heavy exercise, I try and avoid that. However, if you're someone who really needs to get your workouts in, we try and at least try and keep those in a way that we're not doing heavy lifting in those workouts or extended running in those workouts for a 2 to 4 week period.
Excellent. Thank you very much.
Yeah.
Well, we're coming up to the top of the hour. This has flown by. Lynn, I guess I need to check in with you, make sure we're all set on questions. Anything else that we need to talk with Dr. Thakkar about from the audience?
We have a couple questions here that are on the same line of questioning. It looks like William has a question about, it looks like he had the TIF procedure, but it was just a straight TIF and he has a hiatal hernia. And so he's wondering what his options are now. He's having some challenges with swallowing. And then Kawar is asking too, what's the difference between just straight TIF and TIF with a hiatal hernia repair? So maybe you could address both of those real quick.
Yeah. So I think in the first circumstance, so the one that there was a straight TIF and there may have been a hiatal hernia present, I'm not sure the size of that hiatal hernia and whether it was able to be reduced with the TIF procedure alone. Sometimes when it's a very small hiatal hernia, we can actually reduce that with the TIF procedure in of itself. The feeling that food's getting stuck or hung up or difficulty with swallowing, I think could be a number of things. So one is it could be related, also I'm not aware, it's not clear as to when that TIF procedure was done. So, the early TIF procedures that were done with the first generation, what we call fasteners, had a bit of challenges with those fasteners, but the second generation fasteners that have been around now, I would say at least 7 years, 5-7 years, if not longer, those hold really well, and the durability and response that we're seeing now in the 5-year data, the 7-year data is very impressive in that regard. So in speaking to the issue that you raised, if it was an early generation, then there's a possibility in that case that the TIF may not have held as well. Otherwise, other possibilities in terms of what could be causing his symptoms, or is the wrap too tight, is another possibility. And if it's too tight, then stretching that area might be an option with an endoscopy and a simple, what we call balloon dilation. Another option, again, if it was something that the area slipped and he's got reflux, that can give symptoms of food getting stuck or hung up. Another possibility is there also an underlying motility disorder of the esophagus where the esophagus doesn't contract in a coordinated fashion? I don't know if he had some of that testing done before that TIF procedure, but if he didn't, it might be time to have that testing done if everything looks normal on the upper endoscopy. So I would say that, in order to manage these symptoms, first and foremost, if there is a small hiatal hernia there currently, that may or may not be a contributing factor to his current symptoms. So I wouldn't say necessarily go in and have that fixed or go in to refix the TIF. I'd say let's do some investigation like we talked about before, diagnostic testing wise, to understand, is it reflux? Is it a slipped TIF that's going on here? Is it too tight of a TIF that we just need to stretch open here a little bit? Or is it something else that we need to treat differently? You said Yeah, you said there was a second question as well from.
I think it was the same question, just really asking what's the difference between a straight TIF and the C-TIF you mentioned earlier with
Right.
concomitantly with the hiatal hernia repair.
Right. So yeah, that would involve working with the surgical colleagues, at least if it's not a straight surgeon who does both. But if it's someone who, if you see your gastroenterologist and they work with an esophageal surgeon, then what can be done together is to perform that concomitant TIF, as you just described, Lynn, which is essentially to reduce that hiatal hernia and tighten that lower esophageal sphincter using that TIF procedure to that 270 degrees at the same time.
Wonderful, thank you. I think that's it for our questions this evening. And Wendy, I'll turn it back to you.
Perfect, thank you, Lynn. Well, Dr. Thakkar, this is the time in the program where we like to just ask our guests if you could just provide any parting thoughts, to those folks who are out there, who are suffering, who may be on the fence about whether or not they go in for treatment. Obviously, we're living in different times right now, as far as the decision making that patients are having to go through when they're considering coming into a facility right now, coming in to see their doctor. What can you share with them that you think might be helpful?
Yeah. The one thing that's a great parting thought to kind of put forward, and what I would say is that gastroesophageal reflux disease is an extremely common disease that affects individuals in the United States, and complications of gastroesophageal reflux disease are quite significant and should not be overlooked. There's 15 million people in the country with Barrett's esophagus. Esophageal cancer is approximately 10 to 15, actually 15,000, approximately 15,000 individuals affected with it on an annual basis. But the incidence is the most rapidly climbing, faster than breast, lung, and colon cancer all combined. And, again, the biggest precursor to this is gastroesophageal reflux disease in the Western world. And so, it's really important that if you have gastroesophageal reflux disease, that you consult with your provider and talk about options to make sure it's kept under control or evaluated to confirm there's no complications related to it, so that we can minimize any potential risk of this progressing further, and as well as to keep you healthy and allowing you to have, a high quality of life.
Excellent, thank you. We really appreciate your expert insights this evening. We truly appreciate the time you spent with us. We hope you'll join us again in 2022. I want to say if you or a loved one, viewers, are out there and they're looking to take the next step in treating their GERD symptoms, please visit our physician locator on GERDhelp.com. You can simply enter in a zip code to find TIF physician providers near you. Also, we encourage you to download our GERD Help patient education app. It's available on iOS and Android. Simply go to your app store and type in GERD Help. That's all one word, GERD Help, to load this free interactive tool that can be accessed for all things GERD, including recipes, articles, and even a journal that you can use to help record your symptoms. Lastly, please join us next Tuesday for a look back at our TIF Talk year in review. I can't believe it, Lynn. We're down to the last one. Watch your news feed for more information on the time, and we appreciate you for joining us. Dr. Thakkar, thanks again for all of your time. We had a lot of members of the audience who send their thanks. So until next time, everybody have a great evening.
Thank you all.